They say never have a white floor or a white car because it shows all the dirt.
I'll see you in a little bit. We're still pretty early. We're still trying for 11:30.
Yeah. Yeah. One is the lab director. I bet he'll sit over there, and then Griniger, the researcher, probably over here. This guy, he's got the goods. He's the boss. More than likely. More than likely, he'll be announcing it. I think. I don't know. The younger guy is grinning.
Yep, that one's on.
And that one is working. but I think that's going to be it.
I was like, we don't logistically know how we do it. She's like, oh, let me check that. I know. I think we did mention this. And if it's done. It's funny because like my sister has my mom's got pretty bad eyesight, my dad has really bad eyesight. But mine is I have to go through both doctors now. I did actually have to wear glasses when I was a kid, but I was supposed to. Don't tell me we have another thing in common. Did it correct itself? Did she do vision therapy? Oh, the shit's scary.
Everybody ready? So we're going to start with Dr. Keith Jerome, who's the head of our virology lab. And then we're going to toss it over to Dr. Alex Redinger, who is, remind me of your title?
Assistant clinical director.
Assistant Clinical Director of the Unified Virology Lab. And then we'll make sure and move the mic once we've switched to Dr. Jerome. We're going to start with Dr. Keith Jerome. Right? He's going to give an overview, and then Alex will provide some more detail about the testing.
Yeah,
If you don't mind, sir, if you say your name, spell it, your title, because a lot of people have
sure. Okay, great. So I'm Keith Jerome. I'm the head of UW Virology and a professor in the Department of Laboratory Medicine, and that's KEITHJEROME. And so today we're talking about some new testing that's coming on at the University of Washington, UW Virology, and this is serologic testing, and that's a fancy word essentially for looking for the body's response to the virus. So we're looking for the antibodies that the body makes when it has been fighting off this virus. This is a really important new type of testing that we haven't had access to before. Previously, we've found the virus itself, so that's great if you're dealing with someone who is infected right now. But one of the other big questions we need to understand is, has a given individual been infected in the past? We've all heard these stories, right? Somebody says, wow, I was really sick in February. Did I have COVID? And we haven't been able to tell them. Once you're healed, the virus goes away. But the body's response, these antibodies actually continue on afterward for weeks and probably months afterward, and we can detect them. So this is the new kind of testing we're starting with today, or that we're talking about today. And part of our ability to offer this early comes from UW Virology's long collaborations with test manufacturers and in test development. So for many, many years, we've worked with manufacturers to understand how their tests perform. We work to make sure that they work as well as the manufacturers say. We work to help them understand and help our doctors understand exactly how to interpret the tests and how to use the results. And we've done that for a long time, and because of our track record, UW Virology was able to get early access to this kit from Abbott. And fortunately, we had the instrumentation already in lab that it goes on. So we were a very logical place to look at this. And so we were able to evaluate the kit. Alex will give you a few more details here in a moment, but I can say that in our own hands, the test seems to be very, very sensitive, that if a person has had COVID, the test detects them with a very, very high degree of reliability. Maybe even more important, the test seems to be very, very specific. That is, if you've had some other virus, even one of the old other coronaviruses, at least in our hands, we're not seeing any false positives with this test. And Alex will tell you about a series of over 300 specimens that we had stored from the pre-COVID days and tested, and none of those came back positive. So this looks like a really fantastic test. The other reason we were excited to work with Abbott on this is that we not only need a test that works, but we need a test that can be delivered to hundreds and even thousands and maybe tens of thousands of people. The instrumentation we have in lab right now could do 4,000 of these samples a day, 4,000 of these tests. Within just a couple of weeks, we'll be able to do 12 to 14,000 a day. And this starts to get us to the point that we can make a difference in the population of our area, get people back to work, and sort of give them back the lives that they were hoping for. So as I mentioned, we've done a number of experiments really looking at the performance of this test, and there's a lot of details about how it works. So I'm going to hand it over to Alex now, who really led those experiments for us.
Great. Thanks, Keith. So my name is Alex all of those guys?
Oh, okay.
All right. Apologies. Thank you.
Anything else?
All right. So my name is Alex Greninger. I'm Assistant Director of the Clinical Virology Lab and Assistant Professor in the Department of Laboratory Medicine. That's ALEX, and then Greninger is GRENINGER. And so for the last 3 or 4 days, we've been evaluating this kit from Abbott. We've run about a little over 400 specimens through it so far. Now, I said the package insert the studies that Abbott did over 1,200 specimens showed a sensitivity of 100% and a specificity of 99.6%, which is quite excellent. It's much better than a lot of the other tests right now on that are being distributed, especially some of the finger prick tests that the FDA is they've registered with the FDA. The studies that we've done first, we worked with our colleagues in the immunology division here in the department. They had been following some patients who were PC known positives, and they had evaluated with other kits, the Euroimmune kit, as well as a laboratory developed test that they had. And they sent those samples, and this assay was able to detect all of those positives, which is a good sign. We ran it, just one thing, we ran it against 50 pre-COVID-19 specimens, no cross-reactivity there. And then we ran against 355 excess sera samples that come to our clinical lab mostly for hepatitis serologies. If you work in healthcare, you have to have a hepatitis B serology. So there's all sorts of reasons why people get those serologies done. We found 14 positives. Of those, about half of them were people who were in the hospital for COVID-19. So it found those cases. People developed immune responses. They'd been in the hospital. And then it found some people who actually had a high prior clinical suspicion, were evaluated for COVID-19. Some even tested and had a negative PCR test. So we also tested against other human coronavirus positive patients. These are unique sera that are available with our colleagues in the Fred Hutch and also in the immunology division, people who had prior infections, PCR positive for other human coronaviruses, and we had blood serum available from them, and we did not see cross-reactivity to those specific samples. So based on these studies, it seems like the seroprevalence in the area, it's hard to extrapolate from this particular population. This is a very biased population, things that are in our hospital lab, but it's low, right? It's probably somewhere between 1% and 2%, but that's sort of just a initial estimate. We'll find out more as we're able to run this on a better selected population for sort of general epidemiology purposes. And I think this really means that one, the test seems to be performing quite well in our hands, as Keith said, and it really indicates how dangerous this virus is and how many people are still at risk currently. Now, again, we don't know. There's certain things we don't know about these IgG. And other viruses, these antibodies are protective. You won't get reinfected. The genetic diversity of this virus is limited currently. But clearly, just from doing this test, we don't know the answer to that question definitively. But this will be the test that allows us to generate that data to understand those important questions clinically. I don't know if I forgot anything else, but happy to take any questions.
Yeah, we can take questions.
Solve the mic issue so you don't have to go back and forth.
Okay.
Real basic question, can the general public get this test?
So the test, like any other test for this virus, will need to be ordered by a healthcare provider, a doctor, another registered healthcare provider. That might be a person's own physician, that might be a health clinic within a workplace. There's a variety of ways, and one of the things we're going to be trying to figure out over the coming days and weeks is how do we best roll this out to get the best information that really allows us again to reestablish the economy and people's social lives. And so that's going to be something that we want to figure out, but the first step is to have the testing available.
Is it a swab? Is it a blood test?
This is a blood test. This will require a blood draw. So this is a needle in the arm. Not a large amount of blood will need to be taken, a couple of ml, and that'll be sent to the lab for this testing.
Do you have to be symptomatic?
No.
I mean, because you're testing for almost everybody, who's going to be allowed to get this test first?
The accessibility of the test is through a physician. So if a physician feels like it's warranted, that'll be available. This test is not well suited for people who are symptomatic. These antibodies take time to develop. So typically they might take 5 to 7 days or even 2 weeks for some people before these antibodies appear. So if you're sick now, you need the test that looks for the virus. This test is most useful to identify those people who have had the infection previously and are better. And remember that from everything we know about the other viruses, having previously been infected is probably, and I say probably, going to give you some protection from future infection and future illness. Now that's what degree that protection happens is something that the entire medical field is trying to figure out now. But having these antibodies is clearly going to allow people to have a higher degree of confidence. For example, being a first-line health provider, being a first line in the grocery stores, all the people who are at risk right now, this can allow some of them to have more confidence in their day-to-day lives.
Are you going to go backtrack into some of the cases that are already out there that you have samples for, like in nursing homes and things like that?
Oh, we're really very interested in studies, absolutely. UW Virology has always been not only providing clinical care, but helping us understand how these viruses work and how we can deal with them. That said, the first priority now is making sure patients get what they need now. So all the research studies take a second tier. They're very important, but they stand behind that. But I think there'll be plenty of opportunity to do that.
If we were testing back in February or January for COVID-19, how do we get those samples? How do we know who was positive and who wasn't? To get those samples?
Yeah, that's a great question. So the sort of sample that this uses, it's sort of the leftover fluid part of the blood, not the cells in the blood, but the fluid part. And that's a very common thing for scientists and healthcare facilities to store for a while. So actually there's quite a bit available from that time, and we'll be able to go back. And that's how we were able to do the studies and study samples from before COVID even occurred, just to make sure that it didn't have those false positives, because some of that has been stored in research studies and other things that we were allowed to use.
Let me get this straight. Does this test differentiate COVID-2 from COVID-19, this antibody test?
So the virus that causes COVID-19 is a virus called SARS coronavirus 2, SARS-CoV-2. And this test does tell antibodies from that from other infections, from other types of viruses. It's very specific for this.
Will you be able to go to like the Seattle flu study and they have samples from like November, December last year, cut them and start tracking how early there might have been cases over here?
So we work very closely with our colleagues at Seattle Flu Study, and they're outstanding scientists. So a lot of what they have are nasal swabs at this time. There are a variety of sources that do have some of this blood, and we'll be working with everybody. And so it'll be bigger than UW Virology. It'll be bigger than Seattle Flu Study. It'll really be, ideally, this will be a nationwide effort to really understand when this got started. But remember, we were the first place. So everything that we can tell points us toward the middle of January for those first introductions, and this will give us a way to confirm that.
I think a lot of people are thinking about drive-in swabbing. You can't really do this with an antibody test.
Yeah, you could do drive-in phlebotomy to speed it up and to protect healthcare workers. It is hard to do self-phlebotomy right now to draw your own blood. But we'll see what happens in the coming months for other tests that might be available for like finger prick. But right now this is a venipuncture test, and that's the volumes that we need for this test.
Is that something you would be pushing for as a doctor, to have this ease of access to this kind of test? Passengers, make it easier to have the walking type of clinic?
Yes, I think it's very important to have this testing. I think it's a low seroprevalence, but I think people want to know, and it helps us understand more about this virus. And that's how we learn about it. Honestly, is by doing this testing.
So when you said that about 1 to 2% of the population, the initial results showed that about 1 to 2% might have this, what is that population? Is that Seattle? Is that Western?
Right. So the population that we're studying is admittedly very biased, right? So we're looking at, people who have blood specimens in the clinical virology lab. So that's I don't want to extrapolate too much from this, but I do think it sort of gives an idea of approximately, ballpark what the numbers are. And we need to do more studies here in the coming weeks to understand in a more sort of general population what the seroprevalence is. But let's say we didn't find 30% of people with antibodies. And it's a question with its asymptomatic transmission that, it's helpful to have this data with the serology tests. I'd also say that we don't have to go back. This test sort of allows you to see retrospectively, right? So we don't have to go back to samples from November or December. We can. You can use frozen samples on this test, but at the same time, you don't have to. You can actually look. And one of the benefits of this test right now is that this virus has not existed in human populations. It's only been here for about 3 months. And so the people who have had the virus have very strong antibody responses.
So you've already established that this test works well. When can we start seeing, healthcare workers, grocery store workers, first responders start coming to test to see if they have antibodies?
So we'll be offering this in the first part of next week. So there's a few last things that we're ironing out in terms of getting the results back to people and their healthcare providers. But you'll see this test early next week.
When you're talking about
Yeah, and so you mean like people will be coming to people will be looking at the doctor's office getting blood taken?
Exactly. People will be going to their doctor's office. They might be going to the health nurse at their place of employment. They might be going to a health department. There's a variety of ways, and we're willing to work with anyone, but it needs to be someone who's capable of doing that blood draw.
there's a limited, finite amount right now of tests we can do. So I'll go back to priority. Everyone's going to be going to their doctor, get me tested, please, and then all those samples will be coming to you. What's the priority?
Well, I think that's an issue we dealt with with the viral testing. And I think some people would argue we were almost too conservative on who we tested early on. So this will be broadly available. We're building capacity to do a lot of tests. I suspect from our previous experience, it takes time to ramp this up. People will hear there'll be People want it, but you've got to get an appointment. You've got to get in. There's only so many bloods can actually be drawn at a given location every day. So people aren't, realistically, not everyone's going to be able to get this test next week. And that's just the reality of things. But we also need to understand, how is this most useful for the average person who was never sick, doesn't think they had it? There's probably not a lot of utility in using up one of these testing slots to say, yeah, you never had it, and you still should be wearing the mask like we've been doing all day until we started this conference. So we do need to make rational decisions about where is this test going to be most useful. And again, I think frontline people who are at places of high risk really should be tested so they know their status. Keeping workplaces safe, for example, is very important. Places where people have to be in close contact. These are all places where this can be used for. And again, I want to make the point that this gives us another fantastic tool to really get the sense that we're starting to turn the tables on this virus a little bit. We can find the virus, we can also find who had it, and find these antibodies. And this allows us to then do this sort of tracing, this control, this containment of the virus that I think is what we need to do to start getting our lives back.
But I think for workers who are trying to decide whether to reopen, this may be a requirement to come back to work.
It's possible that this could be part of workplace back to work efforts. I think there's a question here.
Yeah, so this is based on IgG antibodies, right?
Yes.
You guys tested IgM and the presence of that in terms of protecting being protected from the coronavirus?
So our department has a few IgM tests that they're looking at. Right now, like you said, this test is an IgG test. IgM test can be a little bit more cross-reactive, just a little bit more sort of binding to other antigens. So right now we're going to go with this IgG test, and we'll continue to evaluate the IgM tests.
Just how far back the samples that you received or tested, just how far back do they go? January, November?
Oh, the ones we were looking at were just from the last week, right? Because we actually want to test more current specimens to give the most amount of time for those antibodies to develop. Like he said, really seven days after the virus enters someone is really when you begin to develop these antibodies. So it's actually helpful to wait a little bit longer time period to allow them to develop.
And then to add to Alex's question, we did have a set of samples that were collected before there was COVID anywhere, so before this was even in China. So we were able to go back before this virus had jumped into human beings and look there. And those are the samples where we were very relieved to say everybody was negative, exactly what we would expect. But you may have heard some of the news, some of these serologic assays that have been put out there by other manufacturers haven't performed very well. And so we want to be very, very careful to ensure that this assay performed to the level we expect.
That's my question. How many other tests have you tested? Other than this one you guys are very confident in, but did you compare them to another test?
Yeah. So these have been compared to two different tests right now in the Department of Laboratory Medicine. The advantage of this test is that it is very analytically. You can run a lot of samples in a day, right? So you can run a lot of tests, and the test characteristics are quite favorable. Having 100% sensitivity, 99.6% specificity are really fantastic results.
Ron, over to you on that. This is a big deal. This is a really big deal. Potentially make a huge difference, a big step towards making our work.
Agreed.
There have been so many different tests that there's been a race to try and get something that works every time.
What? Yeah, so I think you've seen, there have been a couple of really big landmarks during this entire COVID outbreak. When we first started to understand there was a virus, and then we understand it transmitted through people, and then we understood it started to get to other countries, and then it came to our country, and it happened to come here in Seattle. And all of those were milestones, and all those things were bad. And then UW Virology started offering a test for the virus, right? And then other people offered tests, and we started to get more and more testing, and that was great. And you saw what we put out earlier in the week, that we've reached the peak right now, and we seem to be on the far side of this curve. That's another landmark, and that's good. And I think what you're hearing today is, yet again, we have another tool. This is another turning point in the fight against this virus. Yeah, so Alex mentioned some of these other tests that have been developed by our colleague Mark Wenner in the Department of Laboratory Medicine, and he's evaluated these, and those have been used for the last couple of weeks. They're kind of harder to do, you can't do thousands of them, and they've been used to identify people to provide this plasma as a therapy. So these are people to identify people who've already made the antibody. Maybe if we take some of their plasma off and give it to the sick people, they'll get those antibodies and do better. So those other tests have been used for that purpose. They'll probably still continue to be used for that purpose. That's not very many need to be run in a day. And again, for this test, we're talking about literally testing thousands of people every day.
This test will help us identify those people to get other testing to be able to come in and potentially give convalescent sera. Absolutely, be very helpful in that way. It's one of our first drugs that we can give here.
Supply chain. So, Abbott Labs has these tests. You're getting a large shipment, it sounds like. How can, or is Abbott Labs going to be able to keep up with this? There's a private lab here in Seattle that is offering the COVID-19 antibody testing, and they're out and they have no idea where they're going to get anything.
So the supply chain has been an issue through the virologic testing, as I'm sure you have all heard. And how we approached that was by having a very diversified set of tests. So if one test ran out of some reagents, we had 2 or 3 other ways to do that same testing for the virus. To some degree, we have that here, and I've mentioned our colleagues in the department who have some other ways to do it. It's hard to match this volume of testing, the amount that we can do. I will tell you, we have been assured that this pipeline is robust, and that we'll be supplied fully with what we need. Generally, Abbott has been a fantastic partner over many years and provided high quality reagents and very good service to us. So we have every reason to believe that that's true. And if we do run into issues, we'll go to some of the other tests and get through as much as we can, but it will be difficult.
Yeah. Well, one of the advantages of this platform is that HIV, hepatitis B, hepatitis C are all run on this platform, and so they're used to making millions of tests a year, and so that the supply chain is in the order of millions of tests per month.
What's next?
That's a good question. So I think for this particular test, we, this is a great test, and we need to. The next thing is going to be actually understanding how the drugs and getting vaccines. One of this test will help us identify people for convalescent sera, which will be helpful, and we need to start seeing the data from the therapies and the vaccines.
So,
diagnostically, this is one of our best tests that we can offer right now.
So Alex and I have been appearing mostly in these sorts of things as diagnostic virologists, telling doctors what viruses they have, but we're also deeply involved in the research of these viruses. And so we're very deeply involved in the trials for therapeutics and also for the vaccines. So a lot of that, particularly as the vaccine studies start to advance and we start to ask questions about are they working, we're part of those teams that will be determining whether these things actually work. So what's next is really turning the tables on this virus, coming up with therapies for the people who are infected now, and ideally coming up with a vaccine that's going to prevent people from getting infected in the future.
Is there a timeline for that at all?
It's going on right now.
Yeah.
Yeah, no, some of the trials have already started, many of the trials have already started, and even more under development, and we're receiving samples in the lab right now from these trials.
I mean, you may know that every day we report how many clinical tests do we do and what proportion of those are positive, and the number bumps around a little bit, but if you kind of statistically smooth it out, you can see we rose and then we came down. And that's all based on the clinical work that we did. But remember that there's a tremendous amount of testing that we're doing at the same time that's simply in support of these research trials. So these never go into those clinical counts, but these are the test of hydroxychloroquine for people shortly after exposure. Does that actually help them prevent ever getting sick? And we're doing all the virology for those studies, for example. So those come to us, and there's a tremendous amount of work that's going on behind the scenes. And we're open 24 hours a day, and I have to call out the people who actually do all this stuff in the middle of the night. Literally at 3 a.m., there are medical laboratory scientists in the laboratory doing this and just trying to keep everybody healthy.
I just have one more basic question. if someone tests positive, if someone tests and they have the antibodies for COVID-19, what does that mean? Does that mean that people may think they're immune? They can go on with their lives? What does that mean?
Well, that's a great question. What does it really mean to have an antibody here, and what does that imply to what you can do? From everything we know from other viruses and other coronaviruses even, having those antibodies should give you some protection. It may not be perfect protection, and what I mean is that it might be possible to get infected again, but if you did, you wouldn't end up in the hospital, okay? You might feel a little off, but then those antibodies pop right back up, take care of it, and you're better. So you got infected, but it didn't really matter. It's more like a regular cold. That's a very possible outcome. From what we know about other coronaviruses, these antibodies probably don't protect you for the rest of your life, so that they probably last for a year or two, maybe 3. But these are all maybes. You can listen, Tony Fauci's been on the news saying exactly these same things. These are our best guesses of what we think will happen with this virus based on what we know about other viruses and other closely related viruses. But it's too early to be sure. And so there is some caution we're going to give everybody. And don't overinterpret these. Don't go have big coronavirus parties or whatever just because you got this test result. And this actually brings up another point I want to make. We are all dealing with uncertainty in this virus, and we're all trying to learn, and questions about how many people in Western Washington had it. Medically we would say, what's the seroprevalence in Western Washington? We know exactly how to make that study, how to do it. We will do it. But to do that study would take us a couple of weeks, maybe even a couple of months to get that perfect scientific number. I can say with confidence is exactly this. What we need right now is some answers, right? So we're giving you guys answers as quick as they're coming out, with all the caveats around this isn't the perfect experiment. Alex told you in a what we would call a convenient sample, samples that have come to our lab for other purposes, we're seeing maybe 3 or 4% positivity. We extrapolate that to say we think that means that the general population is probably more like 1 or 2% in Washington. There's some uncertainty there, but it gives us an answer now, and it allows us to take action now without waiting for the perfect answers that would come potentially too late.
Yeah, so we get the serum in the lab. If we get blood, we have to make the serum out of it to spin it. That takes like 10 or 15 minutes, and you can put it on the instrument. It takes about 20, 25 minutes. So from an analytical standpoint, it's very, very fast. The instrument can report 3 results a minute. And we have multiple of these instruments in the lab. So, that's the hardest part here is going to be getting the blood.
So 3 individual persons or 3 individual serums or
Oh, no.
3 types of what you do?
We have 3 different instruments, right, that we can use for this test, that we could run it on. And so that allows us even higher throughput. And it'd be one specimen per person. Just one tube of blood per person. Is that what your question was?
Yeah, you say detecting, you said it can detect all these other things as well. I didn't know that.
I just meant it could do 3 different people in 1 minute. Like 3 different studies. It can do about 3,000 to 4,000 a day.
Thank you.
Thank you. What's that?
We're gonna have that fight with Rust.
I know, it's really like a tick.
We're fighting.
All right.
Okay, thank
Yeah,
you.
you're welcome. So one is actually test kit. It's actually comes in a box like this. Oh my God! So this is just the box that it comes in because the reagents have to be in a refrigerator. Okay, so I did bring those out. But this is test.
So we're desperate.
Okay. So,
You want to,
yeah, all right. Yeah, keep close up. So, in the picture that Zeus is about to send out, you'll actually see the bottles that come in this that actually contain the reagents. They're actually set on the instrument that does this. You'll actually see them on top of the instrument. You'll see the computer screen that runs things, and it lists some of the various tests that are actually run on this instrument. And then it has our clinical laboratory manager, one of the real heroes in this, who's been there. Honestly, he's been there more than I have, because I have to do some other things like this. But he's been there day and night, so that's very tough on him. And it's actually him sending these on the instrument and actually running some of these tests.
I'd be the suggestion down there or on the table.
What's the lighting best? Just like that? All right, there you go. I had no idea that that was.
I kept telling you.
And look.
Anything else you got in your pocket?
So usually I test so there's tubes inside the reagents, and then once you get it, syrups and starches mixed with the reagent to see if it.
Yeah, you actually put the
You're putting it in an instrument that you already have that you use to spin a surface. Where?
The same instrument that does antibodies. And so it's a well-established laboratory
So that's those pictures. Are those? Is that video available somewhere on the machines? Or is it just normal centrifuge? Is it a centrifuge?
I gotta get one more.
Well, I've seen centrifuges where they're spinning to separate the serum. Is that kind of similar? Reading after this.
Yes.